Neela again. So if you're hearing my voice, you've connected well, and you should be seeing a screen that says welcome, say hello in the chat. Thanks for joining us this afternoon. So today's call is going to be on, it's kind of like an office hour call is how we've called it, which essentially is in April or so, we got together as a large group and did a run through of what the panel reports are and an example of how to use them. And at the end of that call, we provided a few exercises because we figured kind of the best way to get familiar with the panel reports is sort of to dig into them and work with the data that's within them. So today's call is going to be pretty informal. There's a small number of us, so please feel free to speak up and chat in the conversation. What we're going to walk through is those exercises. So we're going to walk through kind of a brief reminder of what panel reports are and a little bit of that background. We're going to walk through each of the exercises, and we're going to share a few resources we've developed along the way to help with this work. So on the call, so you're hearing my voice. This is Anila. I'm joined by my colleague Jody, who you heard from last time, and of course my colleagues Sue, who's from the AMA and Improvement Advisor, and Sandy, who is also an Improvement Facilitator, and she's with Leduc Beaumont PCN. So thank you guys for joining me on the call today. The call is going to be recorded, similar to how we recorded the webinar call earlier a few months ago. And this is just to ensure that for those IFs that wanted to be here but couldn't be, they have access to it, and that we can post it for training purposes later on. So I see some of you have started using the chat, and some of you have not. So because we're going to kind of keep this call a bit informal, it would be great to hear from those on the line. If you could do me a favor and just say hello in the chat. And just let us know if you had a chance to try this exercise or the exercises in this report or not. And if so, what report did you use? So I noticed that, Sandy, you commented that you used a whole combination of reports, your PCN, some sample report, and a physician level report. So others, please just say hello and tell us what you did. Thanks, guys. Perfect. So I see, Jennifer, you used the sample report, and others haven't had time to get to it, which is completely okay. Hopefully you'll learn through this process. Eleanor, thank you, used the sample. Perfect. Another sample. Awesome. And then we have Sarah, who used the physician report. Excellent. Perfect. And others, feel free to also chat in as you go along, and any answer is certainly okay. And let's see. So just a quick reminder on panel reports. So if you were on the call last time, they should be starting to get familiar to you. But as a reminder, panel reports provide physicians with a personalized, confidential summary about their patient panel. And the data that comes into the report is from hospital records and billing activity that physicians already submit to Alberta Health for reimbursement purposes. So panel reports don't require any additional data collection on behalf of the physician. Right now, we're up to roughly 1,300 physicians who receive these reports annually, and the 41 PCNs in the province. I just wanted to share with you guys directly that, so PCN executive directors have received a PDF copy of their report, and they have received a digital copy of their report. So if you personally, as an IF who works within a PCN, if you're interested in seeing your PCN data and you have not yet had access to it, I'd encourage you to contact your executive director directly for that information. The other thing that I wanted to spend a few minutes on talking about is that we recognize that this year we transitioned from PDFs of paper reports, which is what we've been producing since 2011, to digital versions of the report. And the digital versions offer a lot more interactive features that allow you to dive in and dig deeper into the information. But we recognize that the digital version, we've gotten feedback from the field that based on the clinic that you're working in or based on the internet access at that clinic, that sometimes it's hard to navigate the digital report. So what we're going to be doing is that we'll be providing PDF copies this year and digital copies to every physician. So that's a bit of a transition from what we had previously said, where we were going to provide PDF copies only to older physicians who had requested the reports in the past. But now we're going to actually produce PDF copies for any physician who requests the report. So just wanted to share that update with you. In terms of a timeline, I suspect that it's going to happen. The PDF copies will go out anywhere between this week and next week. But when we do the follow-up notes from this call and send out the slide deck, I'll give you more of an exact timeline just so you guys have a sense of that. Jody, anything you would add to that comment around speed or the reports that you think that IF should know?
Yeah, just that we're working on it. We've connected with SAS, the software vendor, and they recognize that there may be an issue in our system, so we're working to remedy that as soon as possible. It's a very technical thing, much beyond my level in terms of what's going on behind the scenes, but we have actually a meeting with SAS next week in person to figure that out.
Perfect. Thanks, Jody. So thanks everyone for your patience as we kind of work through our transition this year as well. So just as a reminder, these are the measures that are included in the report. Now, if you're seeing a physician level report or the sample report, which many of you looked at, these are the measures that you saw. If you looked at a PCN level report, there's an additional 3 to 5 measures that are PCN specific that are not included in this list that you'll see in the PCN report. So just wanted to do a quick reminder of that. So the data is from March 31st, 2018. So remember, there's a 1-year lag in the data that you receive. And the information comes from Alberta Health and Alberta Health Services. And it's both that and the combination of whoever's on the patient panel list that ends up generating the information that flows into the report. And the report can be ordered in 2 different ways. So one option is the confirmed panel report. So this is essentially when a physician provides a list of patients who are on the panel. One of the things I want to point out here is that CII-CPAR currently has over 30 clinics and over 200 providers who are participating in the CII-CPAR initiative. And if you're participating as part of that initiative, the HQCA and Alberta Health are working on a process where those physicians, as part of that initiative, would automatically receive a panel report with that list of patients. So they don't have to do anything further or submit a confirmed list to the HQCA. So that process is still being worked out. And as it gets further along and we know what it is, we'll be sure to talk to the improvement facilitators that are working with physicians who are part of CII-CPAR. Anything you would add to that, Jody?
No. Well, I guess the one thing is, what we're working through is actually figuring out how to get those reports automatically into the hands of physicians. In principle, we've agreed that every physician that participates in CII-CPAR will receive a report. It's just a matter of, how we get those reports to them. So that's the process we're working through, and we're meeting with Alberta Health this week regarding that.
Perfect. So as you have questions about that process, I'd encourage you to contact your AMA representative, Sue, who's on the call, or you can contact us directly and we'll be sure to keep you in the loop as that process develops. So that's for physicians who feel like they have strong panel management processes in place. The other alternative is that physicians who feel like, oh, I don't know if I feel comfortable with the list of patients that are in my EMR, and I'd rather the HQCA estimate based on billing patterns who my patient panel is, and we can do that as well. And then your report can be based on that. So those are the 2 different options, proxy or confirmed. So just as a quick reminder, so on the last call, we had 5 exercises that we thought would give you a good indication of how to use the panel reports and how to leverage the information for improvement. And so with that, I'm going to hand it over to Sue, who's going to kind of walk us through each of these exercises. Though I will say that though we picked out these 5 questions, as you were looking at the sample report or the physician report, if other questions came up for you, because you're like, oh, that didn't make sense, or how would you explain this? Feel free to ask that question as well. We're going to keep this totally informal and have a conversation today. So with that, Sue, I will hand it over to you.
Thanks so much, Anila. I'm just going to share my screen here. And just going to share the right one. Sorry guys, I have 2 monitors up here, and for some reason, it's not doing it the way I did it before. There we go, display settings. Perfect. Can everyone see my screen now?
Yeah, that's good, Sue. Thanks.
Okay, thanks. So, so again, feel free to chat in any questions that you have about anything that you came across in the report, but we're going to focus on those homework exercises that we gave at the last webinar. And so the first item on the try this exercise was using the home page in the report to identify up to 3 areas of strength and 3 areas of improvement. Now, as we mentioned before, we don't expect you to review the entire report measure by measure and cover to cover. We instead want you to understand it as an improvement facilitator first, and then leverage your expertise to highlight what would be important to your physician. So scanning the results at a glance, start with one measure and then dig deeper, and then identify a practice improvement opportunity and take action. Just remember that an item that is green in color is one that represents being in the top 16% of physicians within the zone if you're looking at a physician report. And the yellow in color are those in the bottom 16% of those physicians within the zone. So these were just the examples that we showed last time. So Sandy, what did you find when you reviewed your report?
Yeah, thanks, Sue. So the first slide, if you just show, I noticed when we got to the report, the homepage, I didn't really see 3 areas that were significant in the orange or the green. So there was nothing that stood out. And so I wanted to have a look, and what I saw was that, okay, we did have one in orange. It was 11.6%. It was around their proton pump inhibitor use. But I also knew, and I think this is where we sometimes have an advantage as improvement facilitators, was that I knew that there had been conversation in our PCN around antibiotic use for acute sinusitis. So I wanted to have a look at that, and that was 81.3. I also know that we're just getting started on the opioid response initiative, and so it felt like it was really timely right now to point out where we were with our opioid use, as well as comprehensive care plans, because that's something that keeps coming up. So even if you don't see something in yellow or in orange or in green, it might not be significant. On this slide, what I wanted to point out was that their continuity in this PCN is quite a bit higher, and the clinic continuity is also higher. And I just really wanted that, and I've actually copied that and put it in our newsletter, because I wanted physicians to be aware that all the work that they've done on panel is actually translating into continuity of care and also into their screening. So that's how I used that information on those couple of pages.
Thanks so much, Sandy. So now it's your opportunity to share. And remember, what did you find were the areas of strength and areas of opportunity? So please feel free to raise your hand, and then we can unmute you so that you can share. Or if you would like to chat in your responses to give us your experience with this, we would be happy to receive your feedback that way as well. So Anila, do we have any volunteers that have raised their hand yet? Does everyone know how to raise their hand? Anila, you might want to take us through that.
Oh, that's a good point. I actually might have Jen do that. Jen, do you mind walking through the instructions to raise your hand?
So if you're able to click on your Manage Participants and your chat box and minimize your view, then you should see a little hand in your participant area. If you raise your hand, then it will call our attention to us and we can unmute you so you can ask your query.
And if you're not ready to share any strengths of or opportunities, what, if anything, was surprising to you in the report on the summary page? You'll notice I'm practicing my improvement facilitator skills of waiting for 8.
So Sue, this is Anila. I looked at the sample report, and in the sample report, I think we found something similar to what Sandy shared with her physician. So it looked like there was an opportunity around CACPs, was lower than the PCN or zone average. I wonder if others who looked at the sample report saw that as well. And then we had, it looked like in the sample report, an opportunity, that physician, to improve on antipsychotic use in older adults. Which is a little bit different than what Sandy found in hers. But those are the two things that sort of jumped out in that report as areas of opportunity.
Yeah, and it's really easy to see those, like quickly scanning them in the summary report. I just love the summary report since it came out, and it just makes a difference to be able to quickly scan a report and see what are the things that really jump out at you. Okay, since everyone seems pretty quiet, we're going to move on to the next one, and maybe that will prompt some conversation. So the second item on the try this exercise was looking at the physician's supply of visits and the overall demand of the patient panel, and using the data from the HQCA report to look at and calculate the ideal panel size. And so you remember during our last webinar, we had this example, which I'm just going to quickly go over. And in this physician's panel size, in this example was 2,792 patients that were on the panel. And when we think of our typical full-time physicians panel sizes of being 1,200 to 1,500, this seems like this might have been a little bit higher number of panels. We certainly see those higher panel numbers, particularly in the rural area as well. And this data, of course, is found under panel characteristics and then panel size. The next thing we looked at was the physician's supply and demand. And supply can be found in the total visits to you, which is this line right here. And this physician was able to provide 9,708 visits in the last year of data. And the other thing that I always find interesting is to look at the visits by non-paneled patients. So those patients that were paneled to other people that you saw during that year. We have the supply now, but what was the demand of this panel? We would want to go to the utilization section of the report to find this. So under visits to any family physician, remember that we're wanting to look at the entire panel and not just the visits to this particular family physician. We want to look to all visits. This physician's panel required a total number of visits of 10,834, and so this is the demand of the physician's panel. And when we went through this calculation, taking the supply minus the demand, it gave us a shortage of visits of 1,126. And this means that the patients, that this physician is overpaneled, where the demands of the panel are exceeding the visits the physician has available. And this means that this physician's patients would need to seek care elsewhere. So how do we look at what might be the ideal panel size? So last time we took you through where to find this, a very simple calculator for panel. And again, there are more complex ones out there, but this is just a very simple one to get started with. And that's available on the PACT website under test box 4. It's the balanced panel calculator, and it looks like this. And one of the things that we need in order to make this calculator work is the revisit rate. And again, we want to make sure that we are looking at the return visit rate of the entire panel and not just those visits to this physician. And here we could see the average visits per panel was 3.9. We entered that into the panel calculator, and we were able to determine that this physician's ideal panel size based on this simple calculator would be 1,884, but his HQCA report is telling us that he has 2,792, which means he's overpaneled by 908 patients. We talked about some of the strategies in our last webinar of what you might want to do with that physician and how to talk to that physician about the overpaneling. But let's go and hear from Sandy. What did you find?
So I wrote on this slide, I love this stuff because I really do. I find this fascinating, and I think it's something that physicians respond really well to when you can have a conversation with them. So what we found on this panel, and we had to play around a little bit because we had to use sample data for this, and this physician had 496 patients. So we were curious whether the physician from the last example Sue was talking about might want to move some of the patients over to this physician. So active patients were 496, and what we looked at was that this physician had a 3.8 return visit rate. So those numbers are significant, and that return visit rate is very hard to get anywhere except for in this report. It's very difficult to get from the EMR. So they have a return visit rate of 3.8. And so we put all that into the calculator. We don't have so this physician was working 15 days a week, 15 appointments a day, 5 days a week for 46 weeks of the year minus stat holidays, with a return visit rate of 3.8, and they could handle a panel size of 905 patients, but the HQCA report said they had 496, so they are actually underpaneled by 409 patients. So some of the things that we've been trying to remember out here, for starters, if we find a physician that is new to a practice and they're saying, okay, how are we going to divvy up these patients? What is our strategy? Lots of them want to open their panel to unattached patients right away. And what I've been trying to do is get them to say, okay, let's look at the physicians in your practice that are actually overpaneled, and can we make sure that those patients are looked after first? Are there some that can be moved over to a new physician's panel before we actually look at the unattached, so they're actually looking after their own patients? I think the other thing that we have to look at, and there's information that we can get out of the HQCA report on this. Now this is pretty big overpanel of or underpanel of 409 patients. But there's other factors that you might want to look at. Did this physician take over a panel from a doctor that had retired? Maybe they have older patients, and you can look in the HQCA report and see if these physicians' patients are actually older and if their burden of illness is greater. So the panel size, although it's a calculator that gives you kind of the ideal, it's also important to look and make sure you specify what their age of their patients are as well. So the information on its own is great. It gives you a lot of information, but you have to consider the whole practice. And again, like I said, as improvement facilitators, sometimes we have that knowledge of what's going on in the clinic.
Thanks, Sandy. So now it's your turn again. So please feel free to raise your hand or chat in. I've been chatting to a few people individually saying, hey, what were your experiences with looking at your physician's report? And did your physician have the ideal panel size? What did you learn about supply, demand? Please share.
You may also use quick keys, Alt plus Y, to raise your hand.
Very quiet out there. Also, I haven't seen any other questions that have come in. Anila, have you seen any other questions in the group chat about the HQCA report? This is your chance to ask. We've got Jody here, we've got Anila here, we've got Sandy here. If you have any questions that have come up, please feel free to chat them in and we'd be happy to address them.
Yeah, definitely agree, echo that, Sue. So we actually had one comment from Angela. Angela, I'm wondering if we can unmute your line. And you were, maybe we can unmute the line, Jen, if you're willing to do that. And Angela had a comment about what she learned about their screening rates from the results. Angela, would you be willing to speak to that? You might have to unmute on your end now, if you're muted.
I have unmuted her microphone. As well, you have a hand raised from Brittany Foe, and I will.
Perfect. So Angela's comment, she might be having trouble connecting to us, but Angela's comment was that she learned that screening for breast cancer and the FIT tests were actually quite lower than she would have expected. So she said that was a good learning from her on the top 3, bottom 3 conversation. And then Brittany has her hand raised, so let's unmute Brittany's line.
If she's dialed in, she may have to unmute her own line or identify the extension of her phone number via the chat feature. I've unmuted everyone.
There you go. Make it easy. Okay, you should be unmuted, Brittany.
Oh, good. Oh, hi.
Hey, we can
hear you. Yes.
Yeah, I did ideal panel size recently for a physician using the HQCA report for the return visit rates, and I think the physician, he was wanting to reduce his panel and give some patients to a new doctor in the practice. So this was helpful to give an idea of how many patients he could reduce. And I think he was surprised how much higher his panel was than his ideal panel size. So it was useful.
Interesting. That's great. That was very helpful scenario to be, especially when you have another physician who's joining the practice, and it's an opportunity for everyone to look at their panel and reevaluate for sure. Anyone else like to share anything about panel size? Any of their experiences? Okay, I will again feel free to chat in any questions or anything you would like to share at any time. So I'm going to move on to the next try this exercise item. And we were looking at identifying how many panel patients were eligible for a comprehensive annual care plan or a complex care plan, a CCP, and received one. So again, in the report, in this example that we shared last time, 46% of the patients eligible for a complex care plan received one in the last year of data. Now, Sandy, I know you've been doing lots of work in this area at your PCN, so I'm really interested to hear what you have to say around complex care plans.
Thanks. This has been a real good engagement tool for some of our physicians. So I had actually shared some of our results at the at the annual general meeting some of the PCN level results, and then I had a couple of physicians contact me and say, okay, so what are mine? Where are my complex care plans? And this was a bit of an eye-opener for this one physician that found that he or she had 14% of their patients that actually got complex care plans. So out of the 73 that were eligible, only 10 had actually received complex care plans. And I think the thing that I was saying most to them is that this is work that's already happening. You're doing this work, you're just not taking that next step of setting goals with patients. So okay, you can go to the next one now, Sue, sorry. So that meant 63 patients weren't actually benefiting from complex care plans, and the missed opportunity in billing was $11,844 every year. And so that was significant. Now, I don't want to make it sound like it's about a billing thing. Some physicians respond more to the 63 patients that aren't actually benefiting from it, and some more to the $11,000. But I think the most significant is that they're already doing this work. You know, they're already going through all this stuff with the patient. They're just not taking that step to finish it off. So it's actually a missed opportunity for the patient and for billing. And so what we did as a result with this physician is we did a whole improvement around it, got a team, we went through and did some mapping. This is about the 5th iteration of this map, but they completed it in just early in June, and we're just going to revisit it again in a couple of weeks here to see how it's going, because they've actually now spread that to, this started with one physician and now it's spread to the entire clinic. And so they're now looking at how they can sustain this going forward and using their EMR to mark those patients. As a result of this, we worked on a script with them so that they could reach out. That's the next slide, Sue, actually. They could reach out to these patients, so they had a script, a standard script of knowing what they were going to say to the physician or to the patient when they called them, so that there was no questions. And they've changed it a couple of times since. I think how it spread mostly to the rest of the clinic was because we kept them informed about what was going on with the rest of the clinic. We just kept changing this improvement board so everybody knew what was going on. We posted it in their lunchroom, and so everybody is now able to take that work that was done by that one improvement team and make it work for their population of patients. And so they're finding a couple of things as a result of it. We started measuring, but their measurements have gotten really good now, so they've really made an effort to make a change in this, and really had to change their processes, because of course that changed a bit of the flow with them, between them and the nurse that was working in the clinic, and of course had to look at some of their multidisciplinary team and how they were using it. So lots and lots of work went into this at this clinic, and I think it's something that might be able to be spread through the rest of the PCN as well. And yes, I'm happy to share the script and happy to share the map as well.
We have a comment from Stephanie Balco.
Example. Hi. Sorry, I just wanted to share because I had a kind of a cool example. Just over a year ago, I went. Can you hear me?
Yep, we can hear you.
Okay. Yeah, I reviewed a physician's HQCA report with them, and they didn't have an EMR. He didn't even have a computer in his office, and so it was really interesting to see his reactions to the report. And one thing that he was an older physician, kind of a more mature panel, and his CCPs, where he had almost gotten 100%. So this was something that obviously he cared about, and even though he was paper-based, he must have had a very good process in place to be able to capture all of these patients over time. He also had very good continuity, I think over 80% continuity. So even if you are not on an EMR and you don't rely heavily with computer systems keeping you on track, I guess it's still able to have processes around certain things.
That's great, Stephanie. Thanks so much for sharing that. I had a similar experience with a physician who was on paper who had some really excellent processes, and were able to keep track of it in a spreadsheet. And they were very reliable in being able to do that. And sometimes it's our EMR systems, the way we're entering information makes things, if it's not standardized, it's harder to find those patients. So figuring out a way of flagging those that are eligible for the CCPs. And again, hopefully this will be something, Jody, I'm saying it again, for next year's report, that wouldn't it be nice if we'd be able to see some of those patients and get those PHN numbers for confirmed patient panels. So I'm just putting another plug in, Jody, because you knew I would.
Yeah, no, and absolutely. That's one place we're going to go. We're also going to look at one thing that we've already decided we're going to add for next year as well is looking at those frequent flyers who go to the ED a lot, so more than 4 times a year, and actually provide their diagnoses back as well. So that's in discussions right now. So we're definitely moving forward with providing more actionable data.
That's great. Perfect. Thanks, Jody. Do we have any other hands raised? Anyone else who would like to comment on this exercise, looking at CCPs?
No other hand raised, Sue, but we certainly will, as I think Jennifer asked for the CCP map, and Stephanie asked for the script. So we'll pass that along because I think Sandy said that would be okay. Thanks, Sandy.
Yep, you bet.
That's great. Okay, moving on to the next try this exercise was identifying the percentage and number of patients that had an ED visit for a potentially avoidable condition during office hours. And so the example that we shared last time we got together showed that this physician, 29 of the potentially avoidable ED visits occurred during the office hours, and it's right down here that you can see that. So Sandy, what did you find when you looked at your report?
Yeah, you know, it's funny, when I was looking at it there, I was going, do I have this right? Because I want to, and you guys double check me if I don't have it right. So even though it looked like the number was really small to me, when you actually, or the percentage was really small, when you actually looked at the number of visits, it was like 748 visits, which is a significant number of visits. When I looked at the 1.4%, I thought, oh, that's pretty small, but it's actually 748 visits. And so when you look at that and go that 36 or almost 37% of those happened during business hours for something that was a primary care concern. And so then I really had to say, okay, why is that? So I took that and I actually started looking at our third next available, because I thought in our PCN we measure third next available and it looks pretty good. But when I looked at it closely, I saw that we only have actually 4 physicians who have same day access. Now this fluctuates back and forth, and this is an average that we did. We have 26 that have 1 to 2 days to TNA. And it's important to look at both of these together so we can really start understanding why people are going to the emergency department, and that to understand that the goal of access, and this helps explain why the goal of access in the province is same day access. So we've measured TNA, but the unavoidable ED visits helps physicians start to put those 2 numbers together. So that's something I want to be able to share with them going forward, because it's significant. Most of them work in Emerge here, and seeing patients that are, you know, there for sore throats and things that they could have got into today. I think marrying those 2 numbers. Again, we measure TNA because it's one of our measures for accountability to Alberta Health, but how do we actually make them start to say, how do we make some improvements here?
Yes, exactly. And how do we use that information when we're talking with physicians, for sure. So your chance to share is your physicians panel accessing the conditions. Why might this be the case? What did you find when you were looking at your reports, and what were some of the conversations that you had? And I think we've unmuted everyone, so anyone like to share? I was thinking about how this new report has kind of changed some of the conversations that I'm having with physicians, because if you remember in previous versions of the HQCA report, it really didn't separate out those other hours that looking at weekends and things like that. And so I lots of times people would say, oh, well, those happened all on Saturday and Sunday. And so I really, I've noticed that it's changed the conversation, having the information presented the way it is when we're looking specifically at those office hours. So thank you to Jody and Anila for making that change.
Yeah, and so we have a comment from Stephanie. So Stephanie, I'll call on you, and your line should be unmuted.
Hi. Yeah, Brittany's sitting beside me, and she just reminded me, Sue, I totally agree with you. I think before, and still, when physicians initially see, the amount of ED visits their patients had for primary healthcare concerns, they don't really believe it, and so it's good to show them. But then it's also like it can make them quite defensive, and so when I've had conversations like it's just, and almost every physician that I've talked to, well, you're always going to have those patients who go to emergency no matter what. And so yeah, I just find this one of those areas that there might be more sensitivity to, because it's not something that perhaps a physician can readily do something about. It might take some time and some real investment from them. Yeah, so I just wanted to mention that.
Yeah, totally agree. And I think when I'm talking to physician groups about this, I think it's really an opportunity to dive more into the data. And just thinking back to our patients collaborating with teams, and one of the clinics did actually that. They were looking at their utilization of the emergency department and worked with AHS to actually gather all of their data for a 4-year period of every single patient within the clinic and how they access the emergency department. And that really allowed them to focus in on those high utilizers of the emergency department. And what they found was that those high utilizers of the emergency department were also high utilizers of their services within the clinic. So those patients who had visit more than 25 visits a year to the emergency room had more than 5 visits a year in their clinic, and it really told them that the services that they were providing to those patients maybe were not hitting the mark. And so use the care planning process to focus in on those patients and provide them with a different type of service and a team to support them. And it'll be really interesting to look at their data over the next few years and to see the impact that care planning has had with those patients. Any other comments anyone would like to make?
Sue, this is Anila. I had a comment. I'm wondering if you and Jody could check me on this. So I was looking at one PCN's data for an AGM that I'll be going to, and I noticed that their potentially avoidable conditions was also high. But in their case, they look like they're a group of physicians that they work in a rural community, and they also tend to be the ones that staff the emergency department. of their local community. And so sometimes patients go to see them after hours or other cases to them. So it still looks like they have high continuity, but it also looks like they have high ED utilization. Do you find that in certain communities?
So we've certainly heard stories from communities where patients will call and they will ask who's in the ED tonight, looking for their physicians or what is the schedule this week. So they're using the emergency department to gain more access to their physicians, and often it's those physicians that have longer third next availables that patients are getting desperate. We've even heard of some stories of patients circling the parking lot looking for a physician's vehicle to know whether or not they're in the emergency department. So this is a huge, we see it often in our rural communities, and that's where I think that we really, really need to focus on access of those physicians so that patients don't have to go to those extreme lengths to access the people that they want to be providing the care. I'm sure if you ask those patients where they prefer to see the physician, they would prefer to see the physician in the office rather than the emergency department.
And just some of those, they really aren't emergency visits. The physicians and the patients refer to them as will go to outpatients. So it's for extended office hours.
Yeah.
And Charlotte has just chatted in and said, we looked at our potentially avoidable conditions. We're unfortunately in the bottom 16% of the province. However, we try to approach the subject. I continually get shut down by physicians, but also administration in the health centers. So yes, please unmute
Oh, Sue, Charlotte says she has a lot of background noise, so she can't unmute her line, which is why she chatted that in. And it looks like there's response in the chat of people saying, yeah, very true. We can relate to that.
Yeah, and I think the payment to a physician in outpatients department is of course much higher. It's after hours, and so I can see why you get pushback, Charlotte. So there's all kinds of things to take into consideration, and I think that this is the advantage of, as improvement facilitators, understanding your physician group, so you know which areas you're going to get shut down on and which ones are going to be met with some, oh gee, that's interesting. So I think we do have to be cautious as improvement facilitators where we go with this report.
Yes, exactly. Thanks so much, Sandy. All right, so the final item on the try the exercise was determining the patients in the low continuity category. And in the example that we shared last time, we found that 31.5 of this physician's patients see their physician 80 to 100% of the time, and it was much less than the PCN in the zone. And they also have 68% of their patients with low to moderate continuity. So Sandy, when you were looking at this for your physicians, what did you find?
Yeah, so I looked at this from a PCN perspective, and we had 42.8% of patients that have high continuity, which is higher than the zone and the province, and 19.1% that have low continuity, which is actually lower than the zone and the province. Again, I think it's a result of the hard work that this PCN has done on panel, and so their panels are pretty good, and as a result, their continuity is better. My question that came up for me when I did this was, are our healthy population driving that continuity? So I looked into the patients with moderate chronic disease, and I was pleasantly surprised to see that 48.5% of those patients with a moderate chronic condition had high continuity, and only 15% had low continuity. So I was encouraged when I saw that, and something that I think when we can show physicians something that encourages them, it sort of prompts them to do even better. again, patients with a major chronic disease, the high continuity was 46.6%, and patients with low continuity was 17.1%. So it's not the healthy patients that are driving that continuity. We know for this group of patients with moderate and major chronic disease that the outcome is going to be that much better when there's higher continuity. Always more work that can be done on continuity, so it's really nice to have that sliding scale to show what happens when the continuity improves. I really like that, and I think this is a great conversation point for physicians.
Thanks, Sandy. So this is your opportunity to share. So what did you notice when you were looking at the percent of patients in the low continuity category? Anyone like to share anything? And we're all unmuted, so if someone would like to raise their hand. One thing I did want to mention as a reminder is that when you're using the HQCA report and the electronic version and being able to look at those low continuity patients, like who are those patients on our panel, remember that if you have a confirmed patient list that you can get the PHN numbers, and so that could be a workflow that you work through is, you know, who are our patients with low continuity? And first of all, we might just want to confirm attachment first. Are they still our patients? And if they are, how can we improve the continuity and have a conversation about patient's medical home and the importance of having that relationship with a provider and their team in the patient's medical home. Anila, do we have anyone who would like to share anything?
No hand raises from the chat as of yet.
Okay, well, please feel free to chat in any more questions. And Anila, do we want to go on to the new resources that you're working on?
Yeah, let's do that. So the AMA, so like Sue and her team, and a small group of improvement facilitators, so individuals that you heard today, like Sandy and Stephanie and Eleanor and a bunch of others, are working together. We have a small working group, and we're thinking through what are the tools and resources that improvement facilitators might need to help address some of the common barriers that they may face in the field. And so these resources are essentially meant to help you a la carte, like as you need them. So Sue, if you go to the next slide, we'll give you a preview of what they're going to be looking like. So one of the questions or comments that came up last time on this call is that people felt, well, what if we're talking to physicians who feel like, oh, I don't know if this is my data, and you have to respond to that. What are some of the things that you might be able to use kind of in your toolkit to help respond to that question? And so we're developing two things that are in the process right now. So one is frequently asked questions around data, so things that you can kind of put in your back pocket and be ready to answer. And another one is we're working on a quick, like, it'll be probably a 2 or 3 minute video that's going to help sort of show you where the data in the panel reports comes from. Because sometimes being able to articulate how that data got in the report and why that report exists may help address some of the questions that physicians have. So be on the lookout for that. Every resource that I'm kind of sharing here is still in the process of being developed and approved, but as that happens, we'll be sure to bring it back to the Improvement Facilitator Network. So the next resource, Sue, another question that came up is, as an IF, what are some things that I can do to quote unquote sell this report to my physicians? How can I get them interested in it? So we know a lot from literature and change management that stories can be very powerful for certain physicians and certain groups. And so we're working on collecting stories from IFs and from executive directors and other individuals on how they've used the panel report to guide improvement or service planning in their organization. That, coupled with some key messages, we're hoping to give you pretty soon, so you have access to that and in your back pocket as well. And I love this quote from a PCN ED, so just wanted to share it here. where she calls this report a love note and calls it simpler than her annual car registration, which I thought was really funny. And one more slide, Sue. So the next one is we have one improvement facilitator who says, I've done this quite a bit, and I kind of have a recipe that I essentially follow when I talk to physicians, and sometimes it's different whether I have 10 minutes with that physician or whether I have 30 minutes with that physician. And this IF did a marvelous job of kind of walking us through, here's all the pre-work I do to get ready, here's what my conversation looks like, here are the follow-up items I leave this physician with. And so working on finishing up that and kind of capturing that her experience, and we'll be sharing that with you as well. So all of these tools are being done in collaboration with the AMA team, with improvement facilitators, to ensure that they make sense for you, and we hope to be rolling them out in the next couple of weeks to months, depending on the resource that we're talking about, so be on the lookout for that. And with that, just a quick reminder that if you're looking at a sample report and you're starting to get familiar with the reports and you're interested in seeing a physician level report, I'd encourage you to work with the physician that you might have a relationship with and complete a delegate access form. So it's a one-page form where you fill out information, your physician signs it, and it gives you a copy, digital and PDF when the PDFs are rolled out, to the physician's report. And then you can kind of try these exercises and pull out information from a physician level report. Just a reminder, delegate access is renewed annually. So if you're doing it now, make sure you kind of give the heads up to the physician that you'll probably be back next year asking for a signature a second time around. So with that, one of the other things, to just like this office hour call was really meant to be a conversation, just to ensure that you don't feel alone when you're out there. The AMA is just a fantastic resource of training and this content, and we're here as well, and we have access to Jody, who's like a data genius. So honestly, if you ever run into any type of questions or you can't answer a question that you might have from a physician or a team member, we're here for you, and we're pretty accessible. So thank you. So with that, I'll turn it over. Sue and Sandy or Jody, anything you'd like to add or say to wrap up?
No, no, just that we can, reach out to us if you have questions. We're happy to answer them. We'll get back to you very quickly.
And I think the biggest advice for me is don't be scared of this report. Just dig in and see what you can find. And I'm not a data person. I didn't think I would ever dig into the HQCA report. When we used to teach it at IF training, I used to just push it to Sue and say, you get this stuff, you do this stuff. And now it's something that I use almost on a daily basis. So don't let it.
Love it. And you love it, right?
But I never thought I would. See, there we go.
And Brittany has a question in the chat, and this is something that I've heard before as well. So Jody, when looking at screening rates, is it possible to look at past years or just the most recent?
Currently, we just have the most recent, but we can, as we move forward with different iterations, we'll start putting those in. So you can see over time if your screening rates are increasing or decreasing.
Yeah, thanks for the question, Brittany. It's something that I'd say, wouldn't that be nice if we were able to get to show the PCN's results? And it's always something I've had to pull out from previous reports. But I agree. I think that would be nice to be able to see the trends for sure.
And I think this is also an example of being able to reach out to HQCA to say, hey, would it be possible? Because you're either going to get, no, that doesn't work, we wouldn't be able to do it, or gee, that's a really good thought, we haven't had that before, but you will get an answer from HQCA. So I think they're always open to those kinds of suggestions. If there's something you think you'd like to see, they're happy to hear about it.
Absolutely.
There is a question from Stephanie Belko. In the previous PDF report, I think there were 2 time periods in there. No? Can anyone address that?
For the screening? No, it would have been 1 year in the last report. But like I said, that's definitely, it's just a matter of building that data and tracking it over time. So we definitely can be open to almost any ideas. If there's something that makes your job easier, or if there's a question that physicians want to answer, we're very willing to listen.
That's great. Thanks, Jody. And thank you to all of you for participating in this webinar. We really appreciate your time, and we hope you have a great rest of your day.
Thanks. Bye, everyone.
Thanks, everyone.
Bye.